Okay, now we're going to enter into the lower respiratory tract. Of course, we'll start with that at the trachea. Trachea is also known as the windpipe. This is the tube that we get our air from, right? It's about 11 centimeters long, so we'll say that's about 4.5 inches long, and it extends from the larynx, where we left off in the upper respiratory tract. Now we're in the lower respiratory tract, where the trachea begins. It extends from the larynx to the primary bronchi, so into the thoracic cavity. There's smooth muscle on the posterior aspect of the trachea, with these C-shaped rings of cartilage on the anterior part. These are going to be incomplete rings of cartilage open on the posterior aspect, because on the back side of the trachea lies the esophagus. And you don't want, if you're eating something and the food is going down the esophagus, you don't want it to go bump to bump to bump to bump, because there is full cartilage around the trachea. No, you want the trachea to have smooth muscle on the back and these little C-shaped, incomplete rings of cartilage going around the anterior aspect. So if you do eat some food, when you do eat food, it just goes smoothly down the esophagus and doesn't bump to bump to bump the cartilage on the trachea. Just remember that the trachea is lined with respiratory epithelium. I'm going to ask you again, what is the epithelium of the respiratory system? Correct. Pseudostratified ciliated columnar epithelium. Please remember that epithelium. Pseudostratified ciliated columnar epithelium. All right, so now function. You know I like function. So what's the function of the trachea? It performs a simple but vital function. It furnishes an open way, an open passageway for air to reach the lungs. That's its job. Stay open so air can reach the lungs. Any obstruction, even momentarily, causes asphyxiation, which can be, of course, lead to death. So you want that tube, even though it's about 4.5 inches long, you want to make sure it stays open and is able to get air into the lungs. So the trachea is a tube, looks like this. I'm just going to branch it on out to the primary bronchi like that, and I'm just going to put this C-shaped cartilage around the trachea and the primary bronchi like that. They call this tube, that's the trachea. It's also known as the main bronchus or the main stem bronchus, like that. So bronchi and alveoli. The trachea divides at its lower end here into two primary bronchi. These are the primary bronchi. The right bronchus is slightly larger and a little more vertical than the left. So the right bronchus should appear a little bit larger and a little more vertical than the left, if I drew it that way. But even if I didn't, please note that that's the way it should look. Therefore, where would you think we see most aspiration? If someone doesn't have a really good epiglottis, where that flap will go over the top of the trachea, I suppose it's not working that well. This person doesn't have a good gag reflex, or this person has some paralysis or had a stroke or something. Where do you think the food or drink is going to go? More than likely. Correct. It's going to come down here and into the right primary bronchus and then enter into the lung that way. Because the right primary bronchus is a little slightly larger and a little more vertical than the left one. So aspiration of foreign objects usually end up in the right bronchus. Yeah, they usually end up in the right bronchus. So this is the right. Yep, okay. So this is the right, and this is the left. And then of course this is cartilage going around the primary bronchus, C-shaped, of course, on the trachea. Let's see, so with incomplete cartilaginous rings, like the trachea before it, talking about these two, the bronchus enter the lungs. And once in the lungs, the cartilaginous rings become fully circular or complete. So let's go on and put this primary bronchus into lungs. Now, once they're in the lungs, just note that they are fully circular now. They're going around to help keep them open because of the pressure differences now. Okay? Incomplete out here, but fully circular and complete once they enter the lungs. So you have the primary bronchus is going to divide into much smaller divisions. Let's just see how this works. So, primary bronchus, right? That divides into smaller branches. Let's see. Divides into smaller branches to the secondary. Bronchi. You're going to continue to branch till you get to tertiary bronchi. So I'll just say continues to branch. To now bronchioles. Here at the level of the bronchioles in the lungs, which I didn't draw all that, the cartilage becomes irregular and begins to disappear. So here, this is where the cartilage becomes irregular and begins to disappear. At the level of the bronchioles, the cartilage becomes irregular and begins to disappear. We're going to have many more divisions, so I'll say many more divisions. A lot of branching in the lungs. You wouldn't believe. Yeah. Till you get to the alveolar sacs, or we're going to say alveolar ducts first. Change this. Alveolar ducts, right? At the level of the alveolar ducts, all the cartilage is gone at this point. So no cartilage here. Now remember, cartilage began to disappear at the level of the bronchioles, right? By the time the branches, the bronchus have, the bronchioles have branched out so much, it gets smaller and smaller to the level of alveolar ducts. There is no more cartilage at this point. Then we get down to the main thing, which are the alveolar sacs. Now the alveolar sacs, I need you to realize these are called alveoli, also known as alveoli. This is where air exchange takes place. So remember when we first started the lecture and we talked about oxygen going into a cell and then a cell expelling the carbon dioxide? Well, this is where, for the alveolar, this is where it's happening. Now the alveoli looks like akin to a bunch of grapes. So let me just draw the alveolar duct here, and then let me just put the alveoli here. These little sacs here are the alveoli. Interestingly enough, if you were able to take the alveoli out of the lungs, now you have to realize that down at this level, around this level, these are microscopic now. Not big like you can see here. These are branching, no way I'm going to be able to draw them, but branching to primary, secondary, tertiary, bronchioles, alveolar ducts, and then the alveoli. It's just branching like that. Just get smaller, smaller, smaller. And a lot of branches come off in the lung. The whole lung is filled like that. If we were to take these alveoli, take them out of the lung, now remember they're microscopic, open them all up, lay them out, it would be the size of a tennis court on both lungs. That's how important us humans being able to exchange carbon dioxide and oxygen, that's how important it is. That gas exchange is that important. So that surface area of taking alveoli out and just say we're slicing them and really microscopically, we could lay them out and it will be the size of a tennis court. That is pretty extraordinary. There are about, remember this little squiggly line means about 300 million. I don't know who counted these things, but it's about 300 million alveoli. So that's about 150 million per lung, correct? All right. So these are pretty interesting things to know. I need you to remember how from the trachea, breaking off to the primary bronchus, to the secondary, tertiary, to the bronchioles, many, many more divisions. Bronchioles, at that point, the cartilage becomes irregular, begins to disappear. Then as the divisions get smaller and smaller, please note the alveolar ducts, there is no cartilage, but only in the alveolar sacs, and this is the way I'm teaching it. Some people will argue that there is gas exchange in the alveolar ducts, but for our purposes, I'm going to stick with alveolar sacs are where the gas exchange takes place. Period. That's what we're going to use for our class. This is the gas exchange. That's the big deal. Carbon dioxide and oxygen exchange there in the alveoli, or the alveolar sacs, okay? Now let's look at the structure of the alveoli. So remember that the alveoli are the primary gas exchangers. I just said that. I think you will agree with that. All right? They're effective in carbon dioxide and oxygen exchange. Due to the extremely thin-walled alveolus that comes in contact with the capillaries, this is how you're able to get that blood gas exchange. The respiratory membrane, that's something that we're going to go over. That's a concept that you're going to have to understand, the concept of a respiratory membrane. These are where the gases, the carbon dioxide and the oxygen, when we're talking about gases for humans, we're talking about in general, carbon dioxide and oxygen. This respiratory membrane is where the gases exchange. They go across a membrane. They diffuse across, these gases diffuse across a membrane. The respiratory membrane is something you're going to have to understand. Let me see if I can find a page for you so that I can at least lead you to that. So in our text, it'll be on page 811. 811 is the respiratory membrane. I'm going to explain the whole concept in a minute. The other thing I want to mention to you is surfactant. Surfactant. Surfactant lines each alveolus, and what it is important, I say chemical. It's really a fat. It's an important fat, and that it lines each alveolus, and it decreases the alveolar surface tension, but increases the alveolar compliance. The point is that surfactant is there to help keep the alveoli open. And it prevents the alveoli from sticking shut as air moves in and out during respiration, right? So let's look at the importance of surfactant. Let's draw alveolar duct, and then let's draw this alveolar sac. And for the sake of it, let's just put some alveoli in this sac. And of course they're represented as these little round circles because that's just the way alveoli we're going to represent it. Now, we said the gas exchange occurs where? Well, it occurs here, where these circles are, in this sac. Now, the first part of this too, I mentioned that we have a respiratory membrane. So let me draw a little capillary here. And then let's put some red blood cells in the capillary. I hope this is showing up. There's red blood cells. Nice plump red blood cells. Of course, that's not really a hole, that's a biconcavity there. But anyway, let's see what happens. What I'm going to show you is a respiratory membrane, which the concept you have to remember, and I told you it was on page 811, right? So air is going to come in here. We're mainly interested in oxygen, filling all of these alveoli, just fill them up with oxygen. Then that oxygen is going to subsequently go from the alveoli and the alveolar sac, go through this thin wall, probably a simple squamous epithelium, over into through the capillary onto the red blood cell. That's the goal of oxygen. When we inspire, bring the oxygen in. We're going to bring the oxygen in, and then all these alveoli will be filled with O2, oxygen. That's important. Why? Because the oxygen then has to diffuse, and of course we know it is a gradient, right? Goes across this gradient from higher to lower over to the red blood cell. Now the oxygen is on the red blood cell. We'll just randomly put some oxygen on the red blood cell. The whole point of that is because you need oxygen to go to every tissue in your body. And where does blood go? Blood goes to every tissue in the body. So we breathe in oxygen to get the oxygen to go into our lungs, diffuse across our lungs, into capillary, hop on the blood cell, and then that gets swooshed away to all the cells of the body. But at the same time, because no two gases can hold the same space at the same time, we're going to have carbon dioxide pop off of this red blood cell. Carbon dioxide is here and here. We'll just use a few of them. Pop off the red blood cell and go into the lungs. And guess where it's going to go when we expire? Out into the atmosphere. So that is the whole concept. You got to keep the lungs clear so that the air, the gases can exchange. You don't want stuff, infiltrates coming all in between here, because then that makes it really hard for this respiratory membrane to stay lucid. In other words, you have to have the respiratory membrane intact, and you have to have it clear enough so that the gases can exchange without any compromise. So let me just let's just say, for example, this person has some, I don't know, let's say, well, since it's COVID, let's say it's the pneumonia. So now pneumonia has interceded and it's come all in between, and it's all in the lung, like this, in this alveolar sac. That's what this blue stuff is. It's just all over the place, right? Now this respiratory membrane now is compromised. It's going to be very, it's going to be a lot harder. And I'll put it out here too. It's all in the lung. This is all in the lung. So now you got mucus, you got bacteria, you got it's COVID. So we'll say it's viral, and you got all this in the lung. But anyway, this is fluid, this is exudate, this is some stuff that should not be there. The only thing you want in the lung are these gases, air. That makes it very difficult. The lining now is so much thicker. It's just not epithelium. It's not just a simple squamous. So that's going to really make it challenging for the gases to exchange across this respiratory membrane when you have all this exudate, all this this infiltrate there. And this is what's happening with people, we'll just say that have with pneumonia. And we'll leave it at that, with pneumonia. So the oxygen that came in the lungs when we inspired, when we breathed in, all the oxygen that filled the lungs and the alveoli at that time, now this oxygen is having one heck of a time getting through this blue stuff, this infiltrate, this exudate, to get over to the red blood cell. And at the same time, the carbon dioxide that's on the red blood cell, that is our waste that needs to be exhaled or breathed out, is having one hell of a time getting out. So the CO2 can't get across. It's difficult for it to come through all this blue stuff to get into the lung, to go out, to be breathed out. This is why having a respiratory membrane that is clear is important, so that you can get gas exchange across the respiratory membrane without any problems. Once you start having a problem with that, you can become cyanotic. You get short of breath. Shortness of breath can lead to compromise. Your oxygen levels start to go down. Your tissues don't get the oxygen. Things begin to fail. Organs begin to fail, and you can go on and expire from that. So this is how important having this respiratory membrane free and clear of any exudate, infiltrates, or anything, fluid or anything in there. Keep it open. It should be nice and clear. All this blue stuff, that's a compromise. Okay, you understand that? So that's the respiratory membrane. It should be easy for gases to diffuse across it. When this blue stuff that I'm representing as exudate or some type of, I don't know, pneumonia or whatever, is in the way, it compromises that. The other thing is, we're talking about the surfactant. Surfactant here, we're just going to draw another lung, another alveolar duct, then the alveolar sac. Let's put some alveoli in here. Now, you say surfactant. I mentioned to you before that it is a fat. It's fatty. And the cool thing about surfactant is, let me put this down, surfactant lines each alveolus. Now remember, how many alveoli do we have? That's correct, 300 million. I mean, there's a lot of alveoli. We are definitely aerobic beings. We need a lot of alveoli to make sure that every tissue in the body is saturated with oxygen. So that's why we have so many. Now, with that in mind, this surfactant lines each alveolus. Maybe I need to use I want to make sure that you can see this. It lines each alveolus inside. That's a little funky there, but let's go around each one like this. The surfactant lines each alveolus. Yeah, I mean, that's a lot of them. So that surfactant, also known as lecithin, sometimes call it lecithin, or you may be on the floor and you get some kind of, I don't know, charge nurse or attending that wants to show off and say, yes, so what does the dipalmityl phosphatidyl choline do? And you'll be like, what? And I don't blame you. Because that's just an old-fashioned way of saying lecithin, and then it's an even older-fashioned way of saying surfactant. Those three things are all the same. All right? So dipalmityl phosphatidyl choline, lecithin, surfactant, whatever. It's all a fat. It's going to line the each alveolus. What's the importance of that? Okay. Well, surfactant is there to make sure that the alveoli, when you breathe in and out, especially on the exhale, they don't stick shut. So have you ever, okay, so you're making eggs, for example. Just say you make a sunny side up eggs. You just crack the egg into a pan. And then you want to slide it out of that pan when it's finished. Because they're sunny side up. They're going to still be kind of not really cooked on top. You know how it looks. Kind of still yellow with the white. The only way you're going to be able to do that is if you spray that pan with some kind of non-sticky stuff. And usually it's a fat. Spray it with some butter, put some butter in there, spray it with Pam. In this case, we're just going to say it's Pam. So this surfactant acts like Pam. So that your alveoli, our alveoli, when we breathe in, they're like this. When you breathe in, they're like this. And then when you breathe out, they go down. But then they don't stick. You don't want to, every breath, you have to really suck in air to open those alveoli up. So one way to not have to do that is surfactant. Now, when a baby is born prematurely, what we do in the hospital, you try to, first of all, you try to give the mother bed rest, right? Hey, just lie down. Just go somewhere and sit down. Don't move around. Just lie there for a couple of months. You know how hard that is? But just stay in the bed. So, all right. That's the mother has to do that because she's trying, her womb is the best incubator for that baby. Any artificial incubator is not going to compare to her womb. All right. So we're going to try to get this mother to sit down somewhere so that she doesn't deliver this baby prematurely. Then we stress the mother. We give her cortisol to stress her. And what that does is the baby's like, oh my gosh, my potential mom is stressed. I better hurry up and mature these lungs so I can breathe on the outside. So that makes the lungs able to mature faster in the infant, in the fetus, and be able to handle itself on the outside world. Those two things is what they do. And then the last thing, of course, I mean, you can do a cerclage and try to sew up the cervix and keep the baby in there. Oftentimes that doesn't work. And you stress the mother, etc. So we just try to make sure that the fetus is in the mother's womb until the full term. Now the point is, if that fetus is determined to become a baby and come on out, then all right, the surfactant level is going to be low, and the baby is probably going to have to be put intubated and put on ventilation. During that time that the baby is on ventilation, we can pour some synthetic surfactant down the intubation tube, right? I think I showed you. We can pour a synthetic surfactant down into the tube, and that will start to coat the baby's alveoli, so that when the baby breathes on its own, the alveoli won't stick shut, because it's so hard to get another breath in. If you have to keep thinking about breathing all the time, you use up so much energy. You won't have enough energy to, you won't have time to eat, because you can't, eat and breathe, and that's just going to take up too much of your energy to try to do that. So the surfactant is there to make sure that the alveoli don't close, that they stay open, and that the person can breathe easier, right? I have to take that back. Babies can breathe and eat at the same time, but that is a reflex that is lost. Especially like now, if I tried to eat and breathe, I'm going to aspirate, just like you will too. But babies can eat and breathe at the same time. All right, so that's surfactant. And that prevents the alveoli from sticking shut. And let me just make this point. Oftentimes when people drown, the reason they drown is because the water is coming to the lungs and washed out the surfactant, right? It's come into the lungs, and the water just washed out the surfactant. And of course the lungs are filled with water, and of course you can't get a nice gas exchange with that, because this blue stuff could just be representative of water. It doesn't have to be exudate. But the point is, you got to have a nice intact respiratory membrane. You don't want anything in the way. Water would be in the way. Water washes out the surfactant, and that's going to cause you to have to breathe a lot more. Breathing will be a lot more difficult. Let's talk about the functions of the respiratory system, and there's quite a few here. The functions of the respiratory system. Remember, function is very important on my list of things to know. So, functions of the respiratory system. The bronchial tree, like the trachea, is going to distribute air to the lungs interior. That's the whole purpose of breathing, is to get air into the lungs, right? So if you go through the gas exchange in the alveoli. The alveoli are surrounded by a network of capillaries that accomplish a gas exchange between the air and the blood, right? Functions of the respiratory system include cleansing, warming, humidifying inspired air. Functions of the respiratory system include air purification to remove contaminants, such as insects, dust, pollen, bacteria, before inspired air reaches the alveoli or the terminal air sacs. There's a mucus. So remember, the two things that will help do that. The initial filter, if you recall, is what? The Fabrizier. Correct. The final filter was what? Correct. The mucus and the cilia associated with that, correct? Okay. So then the mucus blanket that is associated with the cilia is about 125 milliliters. That's about 8 fluid ounces. That's about 4 fluid ounces, let's put it that way. 125 milliliters is about 4 ounces, okay, of mucus that are produced daily. And it covers the lining of the air distribution tubes. The cilia, which are millions of these hair-like structures that are microscopic, by the way, are in association with the mucus blanket, and they beat in one direction only. They beat up towards the pharynx, up and out. And they're beating like this all the time. Sometimes in the morning you may have a little mucus in your throat. That's because they've been beating all night and you've just been laying in a supine position and you weren't able to kind of get it up. But in the morning you'll go and clean yourself, brush your teeth and get the mucus out of you. But if you've ever heard a smoker's cough, first thing in the morning usually, they have to try to cough up any mucus that's been stagnant in their bronchioles, because their cilia is paralyzed. Like ours beats like this, boom, ba-dum, boom, ba-dum, boom, ba-dum, boom. Theirs beats like this, kind of like it's on crutches, like something's up with it. So it's like their cilia is like paralyzed. Okay, now we're going to go on and continue with the lungs. The lungs, of course, are located in the thoracic cavity, which are in the chest wall. They extend from the diaphragm to slightly above the clavicles, and they lie against the ribs both anteriorly and posteriorly. So let's just look at the lungs. Here we have the right lung and the left lung, right? So we're going to make the left lung a little more concave. We're going to put in the clavicles, and then I'll just put in the diaphragm here. And the clavicles up here. So the lungs lie slightly above the clavicles, and of course it rests gently on the diaphragm. Both right and left lungs are concave structures, mediastinal structures. A little more concave on the left than the right. So let me just make this a little concave here, but a little more concave on the left than the right, because it's going to make way for the heart. Of course, this is the right lung, and that's the left lung, right? In the thorax, you have the structure of the thoracic cavity. You have pleuras. You have the parietal pleura and the mediastinal pleura. These pleuras are really linings, and they line the entire thoracic cavity. The pleuras adhere to the ribs. Now remember, the lungs are encased in the rib cage. So say this paper is the lungs. You have the posterior ribs, which are my fingers, and you have the anterior ribs. So they hold or case the lungs this way in the mediastinum. So the pleuras adhere to the surfaces of the ribs, the superior surface of the diaphragm, and it helps to partition off the mediastinum. In other words, it kind of has a lining around the esophagus, lining around the trachea, the large blood vessels, the superior vena cava, the aorta, and of course the heart. So these are all partitioned off like little packages of their own with these pleuras. The visceral pleura, of course when you say visceral, you want to think of the organ itself. The visceral pleura covers the outer surface of the lung. So you think about the lung in this case as having the visceral pleura. The lung itself has got a nice lining over it. It lies against the parietal pleura, and it's separated by a pleural space. That pleural space has just enough fluid in it to reduce friction, and it adds for lubrication. You don't want any friction when you're trying to breathe. It helps you to breathe easy. So just the bit of the separated pleural space with just enough fluid in it for lubrication allows for no friction and easy breathing. Functions. Functions of the thoracic cavity. Of course, the thoracic cavity, which is your chest, plays a major role in the respiratory system. Breathing changes the shape of the thoracic cavity. Now, breathing on its own just changes the shape of the thoracic cavity. The diaphragm contracts, okay? It flattens out and pulls the thoracic cavity downward. And that way you can increase the volume of the thorax. When the diaphragm relaxes and it goes back to its resting dome-like shape, the volume in the thoracic cavity decreases. So this diaphragm is going to move out of the way. So here's the diaphragm. The lungs kind of gently rest on it, but let's get rid of it for now. And let's have it a diaphragm here, like in a dome-like shape. But then when you breathe in, you inspire, your thoracic cavity tends to expand. So how is it going to do that? The diaphragm has to move downward, get out of the way. So we're going to move it downward, flatten out. Now the thoracic cavity can expand. But then when you breathe out, you expire. Now the diaphragm can come back up because the thoracic cavity is now smaller, and it can return to its dome-like shape. And that's how the diaphragm helps with the breathing. It moves out of the way, moves down, flattens out. When the chest is full of air, the lungs are full of air. Then when the chest and the lungs are no longer have the air in it, when we expire, breathe out, then the diaphragm can go back up to its resting dome-like shape. So let's look at the lungs, since we're talking about the lungs, and see what the shape of these lungs are. Let's see how they're partitioned, and if you will be able to tell the right lung from the left lung just by looking at it. Already you know that the left lung is a little more concave than the right to make space for the heart. Let's take a look at this. This tube here, as soon as you see it, you should know that's the trachea, or the main stem bronchus. Here, the primary bronchi here, with the cartilage going around. This point here, by the way, is called the carina. When we intubate, we put the tube down. You kind of want it to be right here at the carina. So you don't want it too much to the right, you don't want it too much to the left, because then only that lung will be aerated. So you want to be able to pull it up like this and have air going with this bifurcation into both lungs. I just thought I'd mention that. All right, so here is, we'll just draw the right lung here, draw the left lung here. This is the apex, or the top of the lung. We know that the clavicles come across the lungs just a tad, and we know that the diaphragm, I'll just draw it in a dome-like shape here. That's the diaphragm. Here we have a horizontal fissure. Fissure means tear, so that's a little tear there. This is the right lung, so I know that is a horizontal fissure. This one is an oblique fissure. So it has two fissures in the right lung, and it makes this lung have 3 lobes. Okay? Let's go over to the left lung. The left lung has an oblique fissure. And actually, That's it. Just one fissure in the left lung. And that divides the left lung into 2 lobes. Now the names of these lobes, I think in your text, the author uses superior, middle, and inferior. We really don't talk like that. But for the right lung, I'll write superior lobe. That would be here. Middle lobe is here. And then, of course, this whole thing will be the inferior lobe. And since there are only 2 lobes for, okay, so that's right. 2 lobes for the left. And we're using those kind of words. You would know that this is the superior lobe, because it's at the top. And then this one's at the bottom, so it's called the inferior lobe. In real life, we say upper, middle, lower. But okay, so yeah, I think your author uses superior and inferior. That's fine. And what is this? What do the lungs rest on? Of course, they rest gently on the diaphragm. So we just say that the left lung is missing a lobe because it had to make way for the heart. We'll just say that. So you'll remember that the left lung only has 2 lobes and the right lung has 3. So let's just give these lungs some problems and see how this works. You remember too that the right lung has a case for more inspired aspiration than the left because of how the primary bronchus is. Okay, just so you'll know, let's put something in this lung here. Let's just say it's TB, because tuberculosis loves to be in the upper portions of the lung because it's more aerated there. So this is up here. This is the upper lobe. I know your author calls it superior, but we're going to call it upper. And it's on the right. So this would be the right upper lobe, and we'll say that's a TB. So for this one, the middle, it's still on the right, correct? It's the middle lobe. And we'll say in this one, this is just a mass. This is TB. So we'll say this is a right middle lobe mass. We don't really know what it is yet. We haven't gotten a biopsy of it, but we just saw it on CAT scan as some mass there. Here, this is the inferior lobe. That's what your author calls it, but in real life, we call it the right lower lobe. And for this one, we'll say, since it's still on the right, this really went deep. We'll say this is an aspiration. So this person just drank something too much and it just went over here. All right. So right upper lobe TB, right middle lobe mass, right lower lobe aspiration. Let's look over here. This is upper and lower lobe. In real life, that's the way we call it. Usually we don't call it superior and inferior, but let's look on this left lung and let's put something in here. Maybe since this is what's going on now, pneumonia, we'll put that there. And we will call this a left upper lobe pneumonia. And then whatever thing we put here, we'll just say that it's a cancer, CA, the big old CA. This is a left lower lobe cancer. And that's the way when you discuss things on clinical, that's the way you'll describe things. So your diaphragm, your apex, where your clavicles are here, and then your lobes, your upper, your middle, your lower. Your author says superior, middle, inferior, but you get the point. And your upper and lower lobes on the left lung. All right? I think the last thing we're going to discuss today is how to breathe. I always find that to be fascinating, that there is a reason on why we breathe. So I'm going to introduce we finished with the anatomy portions now. We did the upper respiratory tract and the lower respiratory tract. I want to glean into the respiratory physiology now, but I want to leave you with how we breathe physiologically, and that will have to do with pulmonary ventilation. Pulmonary ventilation equals breathing, for lack of a better definition. We're going to just say loosely, pulmonary ventilation equals breathing. Inspiration, this is air that moves into the lungs. Inspiration, air moves into the lungs. Expiration, air moves out of the lungs. The reason we breathe, and I know you know this already because we talked about this in the cardiac when we did the heart, on why fluids move and gases move. Why? Because of a pressure gradient. There's a difference in pressure. We breathe because of a pressure difference. Air, like, is a gas, and like fluid, it moves down its pressure gradient. In other words, it moves from a higher pressure gradient to a lower pressure gradient. Air moves from a higher pressure to an area of lower pressure. Keep that in mind. It's the same concept that we learned when we learned about fluid and how blood flows. This, we're just saying the fluid was blood. In this case, the gas is air. It moves from due to a pressure gradient, a difference in pressure. The atmospheric pressure is 760 millimeters of mercury. That is the atmospheric pressure in this room, and I would say at on the campuses, unless you live like on the high mountains of Colorado or the low depths of, what's low? New Orleans, you're going to have a atmospheric pressure of about 760 millimeters of mercury. Millimeters of mercury are the units for pressure. So let's see how that pans out. Your number to remember, the number du jour is what? 760. 760, what are the units for pressure? Millimeters of mercury. That's correct. So let's see how this looks. At the end of expiration, just before the beginning of an inspiration, the pressure in the alveoli equals atmospheric. What's atmospheric pressure? It says 760 millimeters of mercury. This is atmospheric pressure. And I'm just saying in general, like, fortunately, it doesn't change that much if I leave my home, go outside, or if I was on the moon, that's totally different pressure. I'm way up in Mount Kilimanjaro, totally different pressure. Down in the depths of the ocean, totally different pressure. I'm just saying, just normal. Our atmospheric pressure is 760 millimeters of mercury. That's the number to remember. So at the end of expiration, just before you take a breath in, that pressure difference is equal. Alveoli pressure equals atmospheric pressure. Here's the alveoli duct, here's the alveoli, right? And all of this stuff, this whole whiteboard is the atmosphere. Just before inspiration, so after you expire, then you inspire, these two pressures, and I'll just say atmospheric, they're equal. They're both 760 millimeters of mercury. When two pressures are the same, you aren't going to get any air movement. When two pressures are the same, there's not going to be any movement. All right? Air is neither entering or leaving the lungs because both pressures are equal. If I had a twin, same build as me, same weight, same, everything just identical to me. And I'm pushing her, and she's pushing me, pushing her, she's pushing me. We're not going to go anywhere because we have the same strength because both pressures are equal. You understand that? When both pressures are equal, there is no gradient. In other words, there is no difference. So nothing's going to move. You got to have a higher pressure and a lower pressure for something to move. And that way, that's the only way air is going to move in and out of our lungs. So keep that concept. Pulmonary ventilation, which we said earlier, is slightly equal, but not quite the same as breathing, but we're going to use it as that. Pulmonary ventilation is equal to breathing. In our case, that's the way we're using it. This is accomplished once a gas pressure gradient has been established. You have to get a difference between the lungs and the atmosphere. You have to get a difference. So how are you going to do that? Atmosphere is going to stay the same. This is the number to remember, 760 millimeters of mercury. It's not going to be changing that. We aren't going to be going to Mount Kilimanjaro. We aren't going to be going to the depths of the ocean. We're just going to stay at 760 millimeters of mercury. So how are we going to get a pressure gradient? How are we going to get a difference? I'm glad you asked that question. Excellent. So let's look at this. We're going to put a line here. You're going to fill this line in a minute. I'm going to just put a definition here. That's all I'm going to do. And I'm going to atmospheric pressure, okay, is greater than pressure in the lung. Then I'm going to put another definition here. Pressure in the lungs become greater than atmosphere. Okay? Now, when these two pressures are the same, they're equal, no gradient, I'll say no movement. We got to have a difference between the lung and the atmosphere. Atmospheric pressure greater than pressure in the lungs. Okay. Let's draw the alveoli here. That represents the lungs. And then all of this whiteboard is going to represent our atmosphere. So we just say that that's the atmosphere. What is the atmospheric pressure? You know it. It's 760. So this whiteboard is our atmosphere. This room is our atmosphere. All right, so 760 millimeters of mercury is the atmosphere. That's not changing. That's not going to change. But what can change, though, is the pressure in the lungs. So in the lungs is 757 millimeters of mercury. What does this say? The atmospheric pressure 760 is greater than the pressure in the lungs. The lungs is only 757. 757. The air or the gas is going to move from a higher pressure to a lower pressure. This is simple. Don't make this difficult. 760, say it's dollars, $760. Would you say that's more or less than $757? Correct. 760 is greater than 757. In the lungs, what is it? 757. That's less than 760. Gas, air, is going to move from a higher pressure to a lower pressure. So which way is this gas going to move? Correct. From the atmosphere, from a higher pressure into a lower pressure. That's right. Air is going to move into the lungs. What does that make that? That makes that inspiration. I gave you this definition earlier. Air that moves into the lungs is inspired, inspiration. Inspiration, air moves out of the atmosphere and into the lungs. Let's remember that. Let's look at this one. Let's draw the alveolar duct. Put the alveoli here. What is the atmospheric pressure? 760, people. Remember that. Let's get a different color. That's 760 here. 762 millimeters of mercury here. Hope you can see that. I'll say this is 762 just to make sure you can see it. I'm not sure. That's what the lung has in it. A lot more pressure. How does air move from a higher pressure to a lower pressure? Is 762 millimeters of mercury greater than 760 millimeters of mercury? Yes, it is, by 2 millimeters of mercury. Yes. So it's going to go from a higher pressure to a lower pressure system. Gas is going to move from a higher pressure to a lower pressure. From the lungs to the atmosphere. What is that called? That's called expiration. 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 Pressure in the lungs become greater than atmospheric. This is how we breathe. The thoracic cavity is the key to establishing the pressure gradient. Contracting and relaxing these respiratory muscles, the diaphragm and the intercostal muscles, this changes the size of the thoracic cavity, thus allowing for pressure gradient differences and allowing us to breathe. Okay, you guys, that was it for that lecture. We're going to resume next time with chapter 36. Is that chapter 36? Page 825. We're going into the physiology now of the respiratory system. I gave a brief introduction to that when we learned how to breathe, but we'll pick it up from there and learn a little bit more next time. So look forward to the next video, and that will sum it up. So until next time, I'll see you.